what you're all familiar with sensory potential. Somatosensory potential is to assess the ascending pathway of the dorsal lemniscal pathway.
Yeah, this is Dr. Manal Faham. Thank you all, and thank you, Dr. Shivam, for your elegant speech actually and your work. I have two questions to you. The first one regarding Parkinson's disease. You didn't come along postural instability in Parkinson's. Also, we don't see it frequently, and it has dopaminergic theory, but it doesn't improve with medication actually. And I think it's positive effect because I do have many patients which we really support them, but they keep leaning laterally even when they are sitting, even if they stand up and walk. So I want to know your input and what is the best strategy to deal with this postural instability. Another quick question, if you allow me for the second talk for you. Tremor, you mentioned many causes that can affect the tremor, except migraine. Also, I think migraine can worsen tremor and maybe can trigger the beginning of tremor. And if you know that, you know very well that you can treat both with propranolol and dopamine. And I do have a few patients with what look like tremor, but they improve a lot with management of migraine only. So if we see the trick, what's your opinion regarding? I think there should be study to study if patients have both migraine and tremor, and what is really the effect of that?
Very well said, Dr. Manal. So firstly, for the postural instability gait, so this is an axial symptom we're looking at as we discussed the HMY staging, grade 2, then grade 2.53, we start having the axial symptoms. Yeah. It should not be the presenting symptom. Yeah. But there is a subtype of Parkinson's which is called the PIGD, postural instability with gait freezing. This is a subtype of Parkinson's where they have more of gait problems and more of gait dysfunction. If someone has Parkinson's and after several years, they will have axial symptoms. They will have more shuffling and they will be falling backwards. So that is expected. But you always have to make sure they don't have anything else going on, like your MRI scan, make there's no vascular Parkinsonism. Whenever you see a lower body Parkinsonism predominant, like the hands are okay, but the lower body you see a lot of Parkinsonism, always have to make sure there's no vascular Parkinsonism being an MRI scan. Hopefully there's not an NPH component causing NPH causing Parkinsonism. But tilting towards the one side, there's a piece of syndrome that we can see that usually tells me in my mind it is a red flag for an atypical Parkinson's. So whenever we see tilting on one side with prominent gait symptoms, I would be thinking of MSA as a prominent condition because that can cause a lot of axial dystonia, multiple system atrophy. Now, also dopamine agonists can cause, there are a lot of case reports you will find on Flynn-Salt medication causing PISA syndrome. So, very important to look at the medicines if they are dopamine agonists, remove them because that can cause PISA syndrome. That is reversible. Second question for the, I think whenever the patient is in pain, distress, anxiety, discomfort.